Our objectives were to look at long-term efficacy in this study, as well as to ask the important question, what can we learn about who benefits from CAR T cells by studying the clinical characteristics of patients before and during study entry and correlating those with their long-term outcome? Secondarily, to ask what factors of patients would predict increased toxicity to CAR T cells. This study data set were the 115 patients enrolled on JULIET from around the world, and the primary outcomes were obtaining a durable complete remission or having severe cytokine release syndrome or neurotoxicity. First, we characterized the durability of remission and found that at a follow-up of 36 months, patients who'd had achieved a complete remission at 3 months had more than 75% probability of still having event-free survival, where patients who achieved a complete remission at 6 months had 85% chance of having a durable complete remission, attesting to the durability of response. We also looked at one of the really interesting side effects of treatment with CAR T cells, which is really a class effect for CD19 CAR, not limited to Tisagenlecleucel, which are cytopenias. This is a concern for doctors treating patients because they may have low platelet counts, sometimes for 2 months or longer after treatment with CAR T, well beyond the time you'd expect count suppression from the conditioning chemotherapy, the lymphodepleting chemotherapy that they received. And we found in JULIET that the grade 3 to 4 cytopenias had resolved certainly by a year after transplant and had declined between 6 months and 9 months, suggesting that this side effect of CAR T cells, while we don't fully understand it, is not a permanent disability to the patient. Next, we look at LDH level, which is one of the features of the IPSS score. And here it was very striking that patients who achieved a complete or partial remission, who are deemed responders to JULIET, had significantly lower LDH levels at screening, prior to lymphodepleting chemotherapy, or immediately prior to CAR T cell infusion, the non-responders, suggesting that disease burden at the time of enrollment in JULIET, as well as prior to infusion of CAR T cells, was a significant covariate associated with achieving a complete response. We obtained a lot of data on these patients as part of the study, and in an exploratory analysis noted that platelet counts were also associated with response. And this was a little surprising because it's not immediately obvious why a platelet count would be correlated with remission to Tisagenlecleucel, but it's probably because a low platelet count at enrollment reflects recent and repeated chemotherapy. Patients whose platelet count was low had a lower chance of achieving a durable remission, and their overall survival was poor. 10% survival for patients with grade 3-4 thrombocytopenia compared to 45% survival for patients who did not have severe thrombocytopenia at study entry. JULIET had relatively few instances of severe neurotoxicity, but we did see some cytokine release syndrome, and that was negatively associated with long-term survival. Progression-free survival for patients with grade 3 to 4 CRS at 2 years was about 10% compared to 40% with patients with lower levels of cytokine release syndrome. Severe neurotoxicity was even a more ominous predictor of long-term survival, such that patients with grade 3 to 4 neurotoxicity, less than 10% of the patients we enrolled on JULIET, had all died by 6 months post-transplant, compared to 45% long-term survival among patients without severe neurotoxicity. So taking all these things together in a multivariable analysis, we showed that high LDH, low platelet count, or a maximal grade of neurotoxicity or of 3 or 4 after Tisagenlecleucel infusion were all independently associated with progression-free survival, and overall survival was associated with high LDH and a high level of neurotoxicity. We looked at cytokine levels as well as part of this study, and as one might expect, patients who had progressive disease with a high level of tumor burden had high cytokine levels, high ferritin levels. Interestingly, patients who achieved a complete remission without experiencing CRS really did not have elevated levels of any of these cytokines, suggesting that it's possible to dissociate the efficacy of CAR T-cell from things like cytokine release syndrome. So in this study, we conclude that multivariable analysis showed high baseline levels of LDH, a marker for the level of tumor burden, and was independently associated both with progression-free survival and overall survival, while low platelet counts at study entry were also associated with poor efficacy, again, presumably because that represents an extensive prior therapy, another surrogate for more refractory disease. Patients who developed grade 3 to 4 CRS or grade 3 to 4 neurotoxicity also had poor outcomes. And serum biomarkers confirmed that patients who had progressive disease or stable disease as their best response had higher levels of inflammatory markers than patients who achieved a complete remission, again, presumably reflecting the tumor burden at the time of Tisagenlecleucel and the activation of more CAR T cells. So these data give us some clues about who would best benefit from CAR T cell infusions, namely those patients whose disease is under better control at the time of treatment, and further gives support to the idea that CAR T cell therapy might be moved up earlier in the natural history of lymphoma treatment at times when patients' disease is under better control and disease burden is less. Thank you very much.